Welcome to Nursing 224. My name is Julie Losey and I'll be your instructor for this course. The first topic that we're going to cover in the PowerPoints is nursing care for sensory needs, and this will cover disorders such as glaucoma, cataracts, hearing disorders, and other visual impairments. When we look at the anatomy of the eye, you can notice that there are 3 layers and 2 chambers in the eye, and various types of systems that help the eye to work properly. We're going to talk particularly about a couple as we go into glaucoma. The canal of Schlemm, which you can see is up in the left-hand corner there, and we're going to talk about the trabecular meshwork also in the eye, and those will be a couple things you might want to review in your pathophysiology book so you understand better the disorder of glaucoma. This is just a brief overview of vision physiology for you, how light enters the eye, is refracted over the cornea, goes through the aqueous humor, lens, and vitreous humor in order to focus on the retina, and then this message is sent to the brain via the optic nerve, which is cranial nerve number 2 for interpretation. As you do an assessment of the eyes, you want to look at the general appearance of the face and the eyes, look for any drainage, look for any swelling, any redness, that type of a thing that could indicate some sort of an infection around the eye, like a periorbital edema, that type of thing. Look for perla. Are the pupils equally round and reactive to light and accommodation? Examine the visual fields and all ocular movements. So this would be for a full assessment of the eye. The first disorder that we're going to talk about is glaucoma. This is a major cause of visual impairment and blindness in the world. And it is a leading cause of blindness among African Americans and the Hispanic population, even more so than the Caucasian population. Risk factors are listed there on the slide for you. The higher the age, the higher the risk factor is. If there's a history of myopia, which is nearsightedness, there's a higher risk for glaucoma to develop. And if there's a family history, if the patient has diabetes or some other cardiovascular disease, the risks increase for glaucoma, and also if there's been any eye trauma or prolonged use of systemic or topical steroid medications puts the patient at higher risk to develop glaucoma. So it's important that eye pressures are monitored fairly often when patients are on those kinds of medications. Probably about 2 million people in the United States have glaucoma, and it's noted that there are probably another 5 to 10 million that are at risk for developing glaucoma. If we look at exactly what it is, it's characterized by optic neuropathy. It's called the silent thief of vision because a lot of times in the early stages there are no symptoms except for a narrowing of the visual field. What happens in patients with glaucoma is that there's an increase in the intraocular pressure within the eye. That leads to damage on the optic nerve, which can lead to permanent loss of vision that is gradual and progressive and can eventually lead to blindness if untreated. Intraocular pressure is an obstruction or decrease in any part of the outflow of the aqueous humor resulting from a backup of fluids within the eye. And then, like we said, this puts pressure on the optic nerve, which can result in damage to the optic nerve and then a decrease in the visual acuity and those types of things. The aqueous humor is actually produced in the posterior eye chamber and then flows to the front of the eye and then flows out of the eye through those side canals that you saw on the second slide called the canal of Schlemm. From there, this extra aqueous humor flows into the venous circulation and just gets reabsorbed. The problems occur when for some reason those canals are not a 45-degree opening or larger and the extra aqueous humor cannot drain out, so it builds up pressure within the eye, and then that's what leads to the pressure on the optic nerve and potential blindness and those types of things. Normal intraocular pressure is between 10 and 21 millimeters of mercury. There are several different types of glaucoma. The most common one that we see is primary. This is seen typically in adults that are over the age of 60. You may see it in congenital anomalies with infants and children. Secondary is due to another cause. So in other words, it could be from an infection, inflammation within the eye, and can be affected by cataracts, tumors, hemorrhages, eye trauma, those types of things. When we break down primary glaucoma, we look at different types within this subsystem also. Open angle glaucoma, sometimes you'll also hear it called chronic simple glaucoma, is the majority of the types of glaucoma that we see. Probably 90% of patients have this type of glaucoma. Angle closure glaucoma is only seen in about 10% of patients, and it's also known as narrow angle type of glaucoma. And then you may also see congenital glaucoma, which is something that a child could be born with. There are some pages listed there in your textbook that you can refer to for additional information on these different types. With the open angle glaucoma, the cause isn't really known for sure. There is that hereditary factor that we talked about earlier. And there are not any real actual symptoms in the early stages. So that's why it's called the silent thief of vision, because this pressure can increase, putting damage on the optic nerve, but the patient doesn't have a lot of pain or discomfort going on with this, just loses the peripheral vision. And if not treated, it can lead to blindness and those types of things. Angle closure, on the other hand, is very acute type of a syndrome. It doesn't account for only, like I said, only about 10% of all glaucoma types of patients. So it's rather rare. However, it can happen rapidly, and it can lead to permanent loss of vision if not treated. The symptoms come on very suddenly. The patient will usually exhibit severe unilateral eye pain. It causes nausea and vomiting, and the patient will have an abrupt decrease or a blurring of the vision. They may have an enlarged pupil on that side. They may see colored halos around lights. And if not treated, this can lead to blindness rather quickly. This is a nice depiction of the difference between normal vision on the left and tunnel vision that a patient with advanced glaucoma sees on the right. Glaucoma is diagnosed with several different methods. One is by tonometry, which measures the actual intraocular pressure within the eye. If you've gone to the ophthalmologist or optometrist, you've probably had this done as part of your routine checkup. You may have felt it as the puff of air on your eye, that type of thing. Fundoscopy is used to evaluate the color and configuration of the optic nerve. So the physician will look with the ophthalmoscope to look at the inner workings of the eye and how everything looks. Can also be diagnosed, one method used is perimetry, which looks at visual function and the central field of vision. When you renew your driver's license, this is a test that's done that checks your peripheral vision. And then the last one that's listed there is gonioscopy, and it's an examination of the angle structures of the eye, where it's looking at the iris, ciliary body, and cornea to look at depth of the anterior chamber. Visual field testing is also done. This can identify the degree of central vision that has been lost or is narrowed. The patient may have 20/20 vision even though they are losing their peripheral vision. So this would be something that the ophthalmologist would pick up on during the exam. Unfortunately, there's no cure. However, glaucoma can be controlled. The first line of defense is to try and prevent it from happening in the first place. So early diagnosis and treatment are very important, making sure patients go for routine eye exams and knowing the warning signs. Patients that have a history of glaucoma within the family really should have intraocular pressure measured about every 2 years after they turn the age of 40. And if increased ocular pressure is noted on the exam, the patient will have regular follow-up visits about every 2 to 3 months with medication to see how the medication is bringing down that pressure within the eye. The overall goal is to control the intraocular pressure to bring it back to a normal value, and the way that that's going to be done is through regular medical follow-up visits to the doctor, and to make sure that the patient is following through and being compliant with taking the eye drops and those types of things so that the patient does bring down that pressure. Medications are listed on the next slide. These are typical ones used to treat glaucoma. The patients will be tried on whichever particular medication seems to work the best for them. All of the medications listed here, the end goal is just to decrease that intraocular pressure, and each of these medications just works in a slightly different method in order to achieve that goal. So those are listed there for you, and you can also look in your textbook for additional information on all the different eye drops that are used and the nursing implications for all these different eye drops. For patients that can either not tolerate medication, or if the medication is not bringing down the intraocular pressure significantly, then they may have to undergo surgical management to decrease that pressure within the eye. And there are some different surgery methods that are listed on this slide that talk about ways that they do that. The first one listed is called the trabeculoplasty, and this is actually where a laser will burn that trabecular meshwork so that it opens up that meshwork to allow more drainage of the aqueous humor out of the eye, so that in this effect it brings down the intraocular pressure that way. So each of the surgical methods once again has the same goal as medication, to decrease pressure within the eye. They just each work slightly different in order to achieve that end goal. Good calls for nursing or nursing diagnoses for these patients would be acute pain, sensory perception problems, ineffective therapeutic regimen management, risk for injury, and anxiety. And remember, anytime that you're writing out your calls for nursing, remember they have to have a related to following the first part. So here's some examples of a correctly written call for nursing for your patient with glaucoma. Risk for injury related to loss of peripheral vision, secondary to glaucoma, or pain related to increased intraocular pressure, secondary to glaucoma. Nursing interventions for these patients, to give them pain medications, analgesics, and comfort measures, to try to make sure that the patients are educated and aware that they will need to be on medication for life. So it's important that they don't stop it, or let prescriptions run out and go a few days without it, because the pressure will increase again if that happens. Patients are at risk for injury because they may have some problems with good vision and dim lighting, so make sure that they are aware of those issues. And community resources, if we can get them hooked up with visual impairment resources to help them out. Locally, we're very lucky. We have the Sight Center in downtown Toledo, and there's a phone number listed there. And they give a wide variety of assistance for patients. Part of our education also should be to teach the patient how to correctly administer eye drops. And remember, as a reminder, just to have the patient form a pocket in the lower lid, put drops in that lower pocket of the lower lid, and then close their eyes, and then the patient should hold a finger against the inner canthus of the eye for about 5 minutes, and that will help to decrease systemic absorption of the eye drops. So make sure that patients are educated and know how to correctly give eye drops. The next eye disorder that we're going to talk about are cataracts. They are the leading cause of preventable blindness in the United States. Risk factors are listed there. Advanced age. As a matter of fact, probably for patients that are between 50 and 80 years old, about 1 out of every 6 patients will have a cataract. And for those patients that are over 80 years old, about 85% of those patients have cataracts. Environmental factors also are risk factors, especially those patients that are exposed to UV light rays on a routine basis, maybe because they work outside or they're outside quite a bit. It's very important that they wear good sunglasses to protect their eyes from the ultraviolet rays. Cigarette smoking and heavy alcohol consumption can also increase the risk factors for developing cataracts. And gender-wise, it is more common in women. And medications such as corticosteroids also increase the risk for patients developing cataracts. Many systemic diseases such as diabetes, the patients could have multiple trauma to the eye, or patients that have nutritional deficiencies are also at higher risk for developing cataracts. A cataract is described as a clouding or opacification of the lens. You may have seen this in older patients before. It leads to a gradual blurring of the vision. Cataracts are painless, and eventually the patient will have significant visual loss if they are left untreated. They'll have night glares when they're trying to drive, and decreased color perception also. So the next slide shows some actual different types of cataracts that you may see in clients. Congenital could be, one cause might be from the mother being exposed to rubella virus during the first trimester of pregnancy. Senile cataracts are just associated with the aging process. They're not really preventable. They're just something that happens as you get older. Traumatic we talked about earlier. Doing safety precautions is important for those patients that may be in a work environment where there's risk for trauma to the eyes due to work hazards. And cataracts can also be formed due to secondary causes, for example, certain eye diseases, diabetes, shingles, herpes, steroid meds, nutritional deficits that we talked about earlier can also lead to the development of cataracts. The picture on the left is normal vision. The picture on the right is a patient that has cataracts. So you can see how the vision is cloudy and blurry. Cataracts are diagnosed in different methods. One is just regular vision can be checked with the Snellen chart, which if you've gone to the optometrist or ophthalmologist, you've seen this chart before. They can also do it with the ophthalmoscope, where they can look at the inner structures of the eyes, the retina, and that type of a thing. And then the slit lamp actually looks at light, uses a light which examines the anterior segments of the eyes. So this is also something that's used if corneal abrasions or foreign bodies were in the lens and that they needed to look for those types of things. Pretty much medications do not play a role in treating this particular disease. It's treated by surgical correction, and nicely enough, that has about a 90 to 95% success rate with surgery. Preventive strategies to help decrease the risk of developing cataracts would be to wear sunglasses to protect from the UV rays, making sure that clients are wearing goggles in the work setting if they're at risk for trauma to the eye or chemical spills to the eye, things like that. And then trying to control systemic diseases that put them at higher risk for cataracts. So for example, diabetics need to have tight control of blood sugars to decrease those risks for different types of eye disorders, those types of things. And like we said, smoking and alcohol play a role. So trying to have patients decrease those lifestyle habits would also help in the decreased risk for cataracts. Pretty much cataracts are going to be on an outpatient basis. The patient is usually in for less than 24 hours and then they go home. So it's very important that that patient, since they are going to have some visual impairment after the surgery, they need to make sure that there's going to be someone there that's going to be with them to help them for those first few days when they're home. They're also going to be given pre-op medications, eye drops to dilate the eyes before the surgery. And we need to make sure that the patient has medications that won't interfere with the surgery, for example, anticoagulants. If the patient is on anticoagulation medications such as heparin, Coumadin, those types of meds, we need to make sure that those are held for 7 days before surgery so that the patient doesn't have a bleeding problem during the surgical procedure. Make sure that the patient understands the surgical procedure, and make sure that the patient has someone who's going to be able to drive them home and that type of a thing and assist with them post-operatively. Surgical management is going to be done when the visual impairment is getting so severe that it's starting to interfere with ADLs and the patient being able to have do the things that they are normally able to do, such as reading and different things like that. The way that the surgery is done for cataracts is that the cataract is actually broke up with ultrasonic vibration. It's called phacoemulsification. This breaks up the lens into little fragments, which then can be suctioned out of the eye, and then a lens implant can be put in. And the strength and the power of that lens implant will be determined before surgery by the ophthalmologist by measuring corneal curvatures and those types of things. So the lens implant will rapidly restore vision and depth perception once that's been put in for the patient. This particular slide looks at a lens implant on the right and actually shows the procedure for cataract removal and that type of thing off to the left of that slide. There are complications from cataract surgery. Some potential complications could include infection, bleeding, elevated intraocular pressure. There's always the risk for retinal detachment, which the patient would see floater spots, flashes of light, progressive loss of vision if they did have retinal detachment. So anytime the patient has abnormal findings or symptoms after the surgery, they should call their ophthalmologist to check and see if that's something that they need to come in immediately to have checked out so that they can make sure that vision is not hampered in any way. Patients should not have a lot of acute pain after this surgery. The site may feel a little scratchy and that type of a thing, a little irritated. They may just have local discomfort, but they should not have acute pain. Another thing that we have to worry about is if that patient has post-op nausea or vomiting from the anesthetic. We need to make sure that we as nurses, that there's an order to go ahead and give them an antiemetic, because any vomiting that patient has will increase the intraocular pressure with the eye and put stress on the recent surgical site. Post-operatively, these patients need to know some of the things we just talked about. Irritation and discomfort are common, but there should not be excessive pain. If they have drainage, excessive tearing, decline in vision, they need to report that. If their pain is not relieved with just over-the-counter medications such as Tylenol, they need to report that. Patients are told not to take aspirin, Advil, or Aleve because these products contain anticoagulant properties. Patients are at risk for injury because of decreased vision afterwards, and they are to avoid heavy lifting usually for about 6 to 8 weeks. So depending on the ophthalmologist, they will put restrictions on how much they're allowed to lift. It may be that they're limited to as low as 5 pounds to 15 pounds, depending on the ophthalmologist's request for that particular patient. They're going to have to wear an eye shield over the operative eye at bedtime, and actually they will have a patch over the eye for the first 24 hours that will be removed by the ophthalmologist when they go for their 24-hour post-op visit. Make sure that they know how to give eye drops correctly. Typically they're going to be on antibiotic and steroid medications, eye drop medications after the surgery. So if they need to administer 2 different types of medications like that, the patient needs to know to wait 2 to 5 minutes between each different type of eye drop. And if they have an eye ointment also ordered, then that needs to be given last. That should be pretty much it on cataracts. The last part of this particular lecture is going to talk about visual impairments, and this is where we're going to look at patients that actually have issues of blindness or severe visual impairment. Legally, being blind is defined in the United States as having a visual acuity with maximum correction of 2200 or less. So that means that their best corrected visual acuity is less than that. So that would be with glasses on, contacts in, those types of things. A second definition of legal blindness is for those patients that have a visual field reduction to a range of less than 20 degrees compared to a normal of 180. So think of those glaucoma patients that had that loss of peripheral vision due to increased intraocular pressure. 20 over 40 is considered a slight visual impairment, but obviously can be treated in those types of things. Causes of visual impairments can be many, many different things. It could be macular degeneration, cataracts, glaucoma, injuries, inflammatory diseases, hypertension, stroke, sickle cell anemia, endocrine disorders such as Graves' disease, diabetic retinopathies, connective tissue diseases such as systemic lupus, rheumatoid arthritis can also lead to visual impairments and those types of things, and patients with AIDS, herpes, all those types of things. So many, many different causes of visual impairments. The impact on the patient with visual impairment is going to limit interaction with their environment. It may also, depending on the degree of their visual impairment, decrease their personal care and their ability to do their ADLs and those types of things. It may decrease social interaction if they're not able to get out to be around other people, and will decrease self-esteem if they feel like they're losing their independence because of their visual impairments. So some of the nursing interactions or interventions that we can do is to try and teach them self-care issues, some ways to maintain their independence. This could be something as simple as, if you have a client with visual impairment that you've just served a plate of food to, letting them know, that the meat is at 6 o'clock, potatoes are at 2 o'clock, that type of a thing on the plate, looking at it clockwise, so that they can have some independence with feeding themselves. Letting them take your elbow as you get up to walk them, those types of things. Assistive devices, we can hook them up with talking clocks, calculators, computers, watches, laser canes, all sorts of things to try and help them promote some degree of independence. So that's very important. And to make sure that these patients are still receiving sensory stimulation, even though they have visual impairments. There are many community resources out there. The National Federation for the Blind, Sight Center of Northwest Ohio that we talked about earlier in downtown Toledo, and there are also many assistive agencies that are out there that we can hook patients up to get them assistive devices, and different things such as talking books, tape players, guide dogs, and other services and things like that.